Good evening, everybody. I really want to welcome you here in this session on the role of beta-D-glucan in clinical practice. I know it has been a long day, and now there is still one session, so therefore thank you very much for attending. But I think the role of beta-D-glucan in clinical practice is something many of us have questions to and are confronted with in our daily clinical practice. And so I really hope after this session you have new insights. And therefore it's my pleasure to introduce to you the first speaker, who is Dr. Oskar Ekelund. He's a clinical microbiologist, director of clinical microbiology for the region Kronoberg and the National Reference Lab for AMR in Sweden. The floor is yours.
Okay, so hello everyone, good evening. My name is Oskar Ekelund. I am a medical doctor, an infectious diseases physician, and nowadays mainly I work as a clinical microbiologist. And since 10 years I've been heading the laboratory microbiology lab in a Swedish city called Växjö. Usually when I'm doing presentations like this, it's on a very different subject, which is much more of my true expertise, AMR and bacteria. But today I'm here to share our experiences from introducing beta-glucan testing in a smaller or medium-sized laboratory in Sweden. More specifically, how we went along to introduce the Wacko beta-D-glucan test. My disclosures, none other than Fujifilm has covered my expenses for travel and accommodation to do this presentation. My intended outline of this talk is to give some background to our clinical needs of beta-glucan testing, also to introduce you to the context where I'm usually working and where my laboratory is doing its work. Also to give you brief recap of the clinical utility of beta-glucan testing for the diagnostics of fungal infections, and also to briefly go through the common features of assays for beta-glucan. Then also to have a look at what beta-glucan assays there are on the market suitable for smaller laboratories like ours. And then in more detail, look at Wacko beta-glucan testing and compared to Fungitel assay, which is the most well-known beta-glucan assay on the market. Some common principles and some papers comparing these two assays. Then I will describe the validation work we did before introducing this into clinical practice, our main validation, a brief follow-up, and then some results of a Swedish inter-laboratory proficiency testing scheme that we participated in shortly after introducing this test into clinical practice. And then some conclusions and summarizing our experience. So this is the context where I'm working. I'm the head of one clinical microbiology laboratory, hospital-based one, or actually two laboratories. We have two different geographical sites in the southeastern part of Sweden. The laboratory is run by the regional government, so we are working on a non-profit basis. Roughly 65 employees, and we provide a wide range of diagnostics in bacteriology, virology, mycology, and parasitology. Annually, we process somewhere around 230,000 samples, and we are accredited according to ISO 15189. And our particular field of expertise is AMR in bacteria, and that has rendered us a few different reference functions. We are the National Reference Lab in Sweden for this. We are also running the UCAS Development Lab for AST of bacteria, and since a couple of years we are working at WHO, and also even more recently appointed as the EU Reference Lab for AMR in bacteria together with two Danish partner institutions. This is the part of Sweden where I work, and our most important task is to serve the population of this geographical area. Our population size is roughly 350,000. We have 4 different hospitals marked here with red markings, 2 smaller ones, 2 larger ones, the larger ones are these with blue markings. The hospitals have a broad range of medical services, oncology, advanced surgery, hematology. However, we do not have allogenic stem cell transplantation in our regions. We also have approximately 50 primary care centers that we serve with diagnostics, and our laboratories are here and there. So on 2 different sites, the basic diagnostics are available on both sites, but specialized diagnostics are allocated to either one of these. And that means that we need to compensate by having well-developed logistics for transportation of samples. So the distance between these 2 cities is 110 kilometers. And then we also have the smaller hospitals here. So we have several daily transports at 8 a.m. in the morning. 1 car starts over here, 1 car starts over here, and they meet somewhere in the middle, exchanging bags in the forest. Probably looks a bit suspicious. And then they return back home, and that happens again at 1 p.m. and 1 late transport in the afternoon as well. So our goal is that our customers, so to say, the clinicians, should not be aware of we have allocated the diagnostics to this place or to this place. It should be smooth and seamless. So what was then our situation regarding beta-glucan in 2024, or before 2024, when we introduced this test? Well, we used the services of an external laboratory in Gothenburg, Sahlgrenska University Hospital, who had been running the fungital test since a long time. We were very happy with their service, but since Swedish mail is not very reliable and not very fast, we had this problem of samples and results being sent by mail. Which resulted in quite a long turnaround time, somewhere between 2 and 5 days. 2 days if we were lucky, but if the sample was taken on a Thursday, for example, and the mail doesn't go on weekends, it could take up to 5 days before we had the results, which was a big problem, of course. The cost per test they charged us was roughly 150 euros. And we saw during 2022 and 2023 an increasing demand for beta-glucan testing, and the 2023 figure was 450 samples in 1 year, and an increasing discontent among clinicians regarding the long turnaround times. Also, it should be mentioned that we do not, even though we have a broad range of PCR diagnostics, we are not providing PCR for pneumocystis jirovecii at our lab, which is of quite importance here. So this brief recap is probably unnecessary. We have a knowledgeable audience here, but as you know, beta-glucan is a major component of most medically relevant fungi, with the clear exception of Mucorales. Also in cryptococcosis and in blastomycosis, it's of no value for the diagnosis. There have been some sources for false positivity being reported, things like hemodialysis membranes, surgical gauzes, certain antibiotics, the use of intravenous immunoglobulins, and nocardia infection, for example. Most of the assays, if not all, utilize this animal, the horseshoe crab, Limulus polyphemus. Fascinating animal, a living fossil. It's more than 100 million years old. Not this particular one, I'm sure, but the species as such. It actually arose before the iron was used as an oxidant transporter. So its blood is copper-based, blue blood, and it has no adaptive immune system, only the innate immune system, which more or less consists of this bifurcated serine protease pathway activated either by lipopolysaccharides of bacteria or by beta-glucan from fungi. Activation of this cascade leads to cleavage of activation of a clotting enzyme and cleavage of a so-called coagulogen and the formation of a solid gel clot. So the blood basically coagulates around the site of infection, And this can then be used for diagnostic purposes, and this substrate can be used for artificial substrate, for example, a chromogenic one, and so on. So this is called the limulus emulsite lysate pathway. So we decided we needed to do something, and we had to look at the market, what assays were available and what could be a suitable choice for us. Well, of course, Fungitel came up. This was launched in 2004, if I'm correct. It's CE marked and FDA approved. It has become sort of the gold standard, mainly because, at least in Europe and in the United States, this is the assay that's been around for the longest period of time. However, for our purposes, this is a bit problematic. You run the tests in a 96-well plate. Every run needs to have 5 calibrators. They should be analyzed in duplicate, and then you have up to 21 samples, which should also be analyzed in duplicate. And the reason for the duplicates, as far as I know, is that the coefficient of variation is quite high, probably above 20%, and the duplicates compensate for this. So the mean value of these duplicates are used for reporting, but however, if the discrepancy is too high between the duplicates, some minority of the samples need to be reanalyzed. We found 2 more tests, Fungitech G, Dynamic Fungus, which were not readily available on the European market. And then there was Fungitel Stat, a simplified version of Fungitel, which is based on the same chemistry, but instead of reporting the quantitative values as Fungitel, it's reported as an index. However, the assay that caught our attention mostly was this test from Fujifilm Wacko Chemicals. It was launched in Europe in 2018, CE approved, but it's been around on the Japanese market for a much longer time, so there is quite a lot of experience from it. The good thing for us is that we would be able to run single samples, or up to 10 samples in a run, on this instrument, which is called a LimuSave MT7500. Time to results is relatively short, and there is no need for calibration, because calibration is done by the manufacturer, and it's lot specific. The reagent costs roughly 25 euros per test at that time. So we had a closer look at these 2, Fungitel, which we were used to, and the Wacko test. Both use the same species of horseshoe crab, Limulus polyphemus. The Fungitel used the colorimetric detection, while the Wacko use actually the time to gel formation measured as turbidity. So there's a difference between the detection methods, and also they use different standards for calibrating. The Fungitel use something called Pachyman, and which is a beta-glucan from some kind of mushroom, I don't remember which one. Lentinan is used by the Wacko assay. This is extracted from shiitake mushroom, and as a huge fan of Japanese cooking, I salute this choice. But this together means that the values reported are very different. Also, the cutoff values are very different. So Fungitel has an 80 cutoff, and the cutoff now for Wacko is 7. It used to be 11, which I will come back to. The lower limit of detection also is different, and this is for Wacko lot specific, somewhere between 3 and 4 usually. We also had a look at what was published on these 2 methods, of course, direct comparisons, and we mainly based our decision on 3 papers, which I will briefly summarize for you. The first one is from Freiburg University Medical Center, retrospective study using archived serum samples stored at -80 degrees. They looked at both candidemia patients, 120 cases, and 63 cases of pneumocystis pneumonia. The candidemia patients were, majority were albicans, 57% if I remember correctly, and the rest non-albicans. As controls for these, 200 patients were chosen, 100 of which had positive blood cultures with bacteria, and 100 who had negative blood cultures. For pneumocystis, unfortunately, they had no separate controls, which is a slight limitation of this study, of course. So how did the results then look like? Well, this is for the candidemia patients. The mean beta-glucan level was quite high with Fungitel, lower with WACO then. Even though both assays had a big difference between the cases and the controls, you could see that the suggested, at that time, suggested cutoff for WACO 11 was clearly not sufficient. So the sensitivity for candidemia was quite a bit lower with WACO than with Fungitel. So what they did then was that they performed the ROC, receiver operator characteristics analysis, and they found and suggested another proposed cutoff for WACO. So instead of 11, they did some calculations on 3.8. But they found that the sensitivity with Fungitel was much higher than the WACO 11, but also still higher with Fungitel compared to WACO, even if this lower suggested cutoff greatly increased the sensitivity of candidemia. For pneumocystis, it looked better. This, as I said, they had no control, so this graph shows the pneumocystis cases, and these are the candidemia cases. So you see there's quite a bit higher values, and actually both with the suggested cutoff of 11 and the proposed lower cutoff of 3.8, the sensitivity was quite high with WACO. So the conclusion here was that there was, for pneumocystis, both performed well. For candidemia, if you're going to use WACO, you need to lower the cutoff, and still it doesn't perform equally well as Fungitel. One limitation with this study, however, is that this was performed on archived sera, some were very old, almost 15 years, and the two assays were not performed in parallel. So Fungitel was performed on these samples several years before the WACO testing was done. So that is, there's at least a question mark if this has in any way affected the results. Second paper is from Leuven. One of the co-authors are actually our chair tonight. So really nice paper of pneumocystis, collecting 116 cases and 114 match controls. Again, WACO versus Fungitel. The cases had clinical and radiological signs of pneumocystis and a positive PCR with a CT value of 28 or lower. The controls had similar risk factors, similar clinical presentation, but negative PCR for pneumocystis. The results were a bit different here, both with the cutoff of 11, or already with the cutoff of 11, the sensitivities were similar between Fungitel and WACO. However, WACO exhibited a superior specificity. Then they also did an ROC analysis, looked at this, and as you see, they are quite similar in shape, and as there always is a trade-off between sensitivity and specificity, you might wonder if the cutoff of 11 was placed with a higher priority of specificity rather than sensitivity. But they also calculated a new optimal cutoff, which was in their study 6.2, and using this, the sensitivities for pneumocystis was similar, but the specificity on WACO was better, and then they also wanted to look at predictive values, and as this is a one-to-one weighted study, they did calculations for a prevalence of 20%, and they then saw that the negative predictive values were really high with both, but the positive predictive value was better with WACO. So the conclusion of this was that WACO was equal or better than Fungitel when it came to the diagnosis of pneumocystis, at least if you use the lower cutoff value of 6. The last paper is from Rome. They had a broader approach. They looked at both invasive aspergillosis, invasive candidiasis, and pneumocystis. The patients were, the diagnosis was done using accepted criteria at that time, and controls were patients with similar risk factors, but who did not fulfill the criteria for proven or probable disease. Again, they compared Fungitel to both the recommended at that time, cutoff of 11, and they also did a similar calculation of an optimal cutoff, which they found to be 7, and they could see with 11, Fungitel was superior, but with a correct adjustment of the cutoff, the differences both for candidiasis and pneumocystis disappeared. However, there was still a slight difference in sensitivity when it came to the diagnosis of invasive aspergillosis. So based on this, we decided to continue with the introduction of the WACO test in clinical practice. What we did was that we wanted, of course, to do our own small verification or validation of this. We did double sampling during 2 years, and from these, one sample was sent to Gothenburg for Fungitel assay, and we then kept one tube frozen at -70 degrees. Out of these, we chose 20 positive samples of different degrees of positivity and 10 negative, and then we compared the results of the Fungitel assay with the WACO results with a cutoff which had then been adjusted down to 7 also in the recommendations from the manufacturer. However, Gothenburg, in the beginning of this small study, they used a cutoff for Fungitel of 100, which was during this period lowered to 80. I don't know the background to this. They did some kind of adjustments of their method and reduced some background noise or something. And we then did a qualitative and quantitative comparison of our results. So first, the Fungitel negative samples, 10 of them, all negative in Fungitel, all negative in WACO, 2 of them, though, with measurable levels of beta-D-glucan, although below the cutoff of 7. Then we had 11 samples which were positive in Fungitel when during the period they used the 100 cutoff. You see all these also positive, measurable values with WACO, but 3 of them, the red ones, below the cutoff of 7. And then Gothenburg changed their reporting using this is how it looked when we plotted them against each other. And then we had some more samples after they introduced the new cutoff of 80 for Fungitel. Here you see a very nice correlation, except for one very strange sample. This was highly positive in Fungitel, negative in WACO. This was, however, followed up. A new sample was taken 5 or 6 days afterwards, and it was completely negative in Fungitel. So we believe that this is some mix-up of samples. We excluded this from further analysis. So when we plotted these, you see quite a nice correlation. The absolute values are, of course, very different. And we were very happy with this, and we decided to introduce this test into clinical practice in February of 2024. Based on the papers, I just briefly summarized, we decided to, apart from the positive samples and the negative ones, we decided to, for all samples with a measurable level of BDG, but below the cutoff of 7, apart from reporting it negative, we added this comment that BDG has been detected, but the level below the cutoff, and this level might still indicate an increased likelihood of invasive fungal infections. If the clinical suspicion is still there, we recommended a new sample. And we were happy with this. We thought this was really a big improvement. We thought we would receive flowers and chocolate from the ID physicians. The chocolate did not come, however. This was what it looked like when we had our meetings with them. They found it really difficult to adapt to the new quantitative value. They have been to national meetings discussing like Fungitel 300 or 600 and different sort of cutoff for clinical decisions, and they were clearly not happy with this. They found it difficult to adapt. And one day, a very upset ID physician called me and said that we have now at least 2 samples with really strange results. We have one patient you have reported a high value of 50, which is very high in the WACO test, and we have almost no suspicion of fungal infection. And we have another patient which was really, really high in Fungitel 1 week ago, and now it's only slightly above cutoff in your test, so this must be something wrong. So we took these 2 samples and also 2 more that they complained about, and we sent them to Gothenburg for a comparison, and fortunately for us, or for me personally, this turned out very well. So there was a very expected correlation between the two results. And if we add those red dots to the graph on the previous page, we see that the correlation is sort of improving all the time. And so for our clinicians, they really decided on this rule of thumb that the Fungitel value is really approximately 11 times the WACO value. This, of course, is not valid for each and every sample, but as a rule of thumb. However, this is quite different from the papers I cited. One of them, the one with old archived serum samples, found a correlation of 21 times higher. I think the Leuven paper was 18 times higher, so I don't really know why we only have this factor, but this was something the ID physicians at least could use for a transitional period to get used to the new assay, the new way of reporting results. Just a couple of months after we started analyzing clinical samples, we participated in a Swedish proficiency testing scheme, which was arranged by a colleague in Umeå University in Sweden. 8 labs participating, 3 using WACO. One of them was us. Lab I have humbly called us lab number 1 here. 3 labs using Fungitel and 2 using the sort of simplified rapid version of Fungitel, the Fungitel stats. And this turned out in hindsight to be a dilution series. And these were the expected values according to the coordinator. And as you see, we had very nice results, very in line with expected ones. And most of these results were very okay. Some exceptions, though. Lab 3 reported a very unexpectedly high level of beta-glucan in sample number 3. I don't know the reason behind that. And even more unexpected was this. I'm not sure how this has happened, if it was something mix-up of samples or when entering the results in the reporting system, because this is very strange. And with Fungitel stat, there was one sample, this number 3 sample, which was generated invalid results for both these. And again, I don't have any explanation for this. But we were very satisfied, at least, with our performance here and continued using this. So how has this then transformed our situation from the one before 2024? Well, during this year, we have analyzed this far, 265 samples. We probably will end up around 400 on an annual basis. The smaller hospitals, the more distant ones, if samples are taken weekdays before 8 a.m. early in the morning, due to frequent transport, we report results the same day, even though we're only performing this assay in one of our 2 laboratories. For the larger hospitals, where the more complicated patients usually are cared for, we are reporting even samples taken as late as 1 p.m. the same day. And if the samples arrive later than this, we report the results the next weekday, next morning after. So this is, of course, a huge improvement in turnaround times. Also, although very unusual or infrequent, we are also able to, since it's very easy and easy to learn, very short hands-on time performing this analysis, we can, in selected patients, also offer acute analysis if the patient is critically ill. And we have calculated a cost reduction of 15%. I think actually this is wrong. I think it's 25%. And even though we are including cost for validation, buying the equipment, participating in EQA, all this stuff, we are saving money clearly. So this is how our ID physicians look now after some lobbying for this method. And they are now, we have no critical questions about the values. They are getting used to this, and they are learning by using the assay. So to summarize, our validation is, of course, very small. It's not big enough to be published in any way, but it has given us we are really relying on this, trusting this assay. In our view, WACO beta-glucan test exhibits comparable performance to Fungitel. However, based on the papers I showed you, we think that all measured values above the lower limit of detection needs to be commented in some way, especially perhaps if the suspicion is candidemia. And for us who are not offering PCR testing for pneumocystis, this wacko beta-glucan test has been become a very convenient, rapid alternative to PCR testing if there is a clinical suspicion of pneumocystis jirovecii pneumonia. And the ability to run single samples make this assay a very valuable tool for us and probably for many other small and medium-sized laboratories as well. And the main challenge has really been to adapting to the wacko values instead of the fungitel values, which we have been using for a long time. And this has resulted in huge benefits regarding both costs and, in particular, turnaround times for us as a laboratory of clinicians and in the end for our patients. And with that, I would like to thank you for your attention and acknowledgements to my colleague Christina Boyesson and to Dominique André, who was the coordinator of this proficiency testing scheme. Thank you.
Thank you so much. Thank you so much for sharing your practical experience with us, because, as said, these are not the things you typically can publish, but which are so valuable to hear, because we have all to go to the same phases, looking to literature, then selecting a test, doing a validation study, then being confronted with clinicians who might not immediately be on the same line, like the different quantitative results, makes them, I think, also insecure about the validity. There are always unexpected results, and then, when you act on it, it may, feel like, this might not be the right decision, or we might have a problem, but then we need to look a bit more in depth and also participate in proficiency. And if we take everything together, I think we can really make valuable conclusions. So then it's my pleasure now to introduce the second speaker, because there will definitely be time for questions from you, the public, but we will keep it after the two talks, because, of course, these two talks are very much related to each other. And so the second speaker is Professor Anne Debourgogne. She's a medical biologist at CHRU Nancy, Université de Lorraine in France. And also she will speak about the diagnostic value of beta-D-glucan in invasive fungal infections, but her focus will be on intra-abdominal candidiasis, I think a clinical entity we are all confronted with in our practice. The floor is yours.
Good evening, everyone. First of all, I would like to thank the organizer of this symposium for inviting me to share our experience using the BDG Wacko Fujifilm kit, and apologize in advance for my French accent. Here is my disclosure of interest. We started using the BDG test in your lab at the beginning of 1992. Before that, the analysis was outsourced to Hanover University Hospital in France using the fungitel test. The analysis is showing a continuous increase. A twofold increase in prescription rate is observed over the period 1992-1995. Today, we perform 4 batches per week with a turnaround time of 1 to 2 days. Given the strong support from clinicians, we decided to carry out a practice survey. The practice survey was conducted between June and July 1995. An online questionnaire was distributed by email. The survey was sent to all prescribers in your hospital. The survey focused on how the BDG test is prescribed and how this biomarker is interpreted by our physician. A total of 47 clinicians took part in this survey. For the first question, do you manage patients at risk of hyphae? 68% of prescribers were managing patients at risk of hyphae. In most cases, BDG were prescribed occasionally at 34%. The following question were asked only if the physician were prescribing a BDG test. For each question, a statement is provided, and the clinician indicates the level of agreement using a 5-point Likert scale by selecting one of the 5 following options: strongly agree, somewhat agree, neutral or no option, somewhat disagree, and strongly disagree. The first question focused on the first question focused on the context in which the biomarker is prescribed. Systematic prescription or regular screening are rarely practiced in your hospital. However, in case of infectious syndrome compatible with hyphae, BDG testing is widely recommended. Despite more mixed options, BDG also seems to be used for monitoring documented hyphae. Now, how do clinicians interpret a negative BDG result? Opinions are mixed regarding a second test on a new sample. A slight majority supports stopping empirical antifungal treatments. Views are relatively neutral when it comes to rule out hyphae, despite the excellent negative predictive value of this test. How do clinicians interpret a positive BDG test? Opinions remain divided on a new sample, even in case of positivity. All respondents are asking additional investigation, such as imaging of a biomarker of fungal culture, and the majority considered that an hyphae to be taken into account, and a smaller majority initiate antifungal treatment. The survey shows that educational action aimed at prescribers are necessary in your institution regarding the relevance of BDG testing and in its interpretation, particularly in the case of a negative result. As part of a thesis of one of our residents, Barbara in the picture, we conducted a study within your patient population to evaluate the performance of the Fujifilm Wako test for measuring BDG level. This is a single center retrospective study. There are 3 objectives: to evaluate the performance of the assay in the studied population, to assess the impact of repeated BDG testing, and to compare BDG level according to the type of hyphae and in case of false positive result. Patients enrolled underwent 1 or more BDG measurements during the period from the 1st January 1992 to the end of February 1994. We have collected demographic, clinical, biological, and therapeutic data. The flowchart of this study includes over 1,000 tests performed on more than 1,000 patients over a 26-month period. On one hand, among the 84% of negative results in yellow, we randomly selected 100 patients. Only 1 false positive was identified in a patient with a probable invasive aspergillosis. Interestingly, in this group, 2 cases of mucormycosis were identified, but the BDG remained negative as expected. On the other hand, 180 patients were studied with an early 700 positive BDG result. Among them, 6% in blue had no diagnosis of fungal infection and was considered as a false positive result, while 10% in purple had a confirmed IFE. These cases are widely, evenly distributed between invasive candidiasis, invasive aspergillosis, and pneumocystosis. In this section, we aim to compare to a group of patients with a positive BDG test, those without an IFE, who could be considered as false positive result, and those with a confirmed IFE. For concerning demographic data such as sex or age, we have no difference between the two populations. We have a majority of men, and the median of age is nearly 60 years old. We identify several distinguished features. The number of BDG tests was higher in the HIFI group, with nearly two tests per patient. The type of immunosuppression differ. Patients with false positive were more often cirrhotic, while those with HIFI were more frequently living with HIV. Finally, the reason for hospitalization varied too. Cirrhosis decompensation was more common in the false positive group, whereas infectious pneumonia was more frequent in the HIFI group. We have no difference concerning treatment and the admission to the ICU unit. We assess the performance of the Fujifilm WACO test in your population using the manufacturer recommended threshold of 7 picogram per ml. We consider only one measurement per patient. We observe the following results. Sensitivity and negative predictive value were close to 99%, and specificity and positive predictive value were above 50%. The ROC curve analyses show good performance with an area under the curve on 0.85. The optimized threshold vary slightly increased to 8.5. Under this condition, sensitivity would slightly decrease, leading to a specificity of 66%. BDG is now included in the 2019 EURTSA recommendation. For candidiasis, the selected marker are T2 candida PCR and BDG above the cutoff defined from the Fungitel kit, confirmed in 2 consecutive samples. The same criteria apply to pneumocystis using a BDG and pneumocystis PCR. Within the WACO Fujifilm kit is this approach of using 2 samples also relevant. When considering 2 measurements within a 15 days period, sensitivity and negative predictive value reach 100%, and the positive predictive value increased to 62%. However, specificity decrease, likely due to the small number of patients, 1/3 of the initial population. We had 2 BDG tests during that time frame. The comparison of BDG levels show lower value and less variation in the false positive group in light blue, with a median of 14 picogram per ml. Moderate value in case of candidiasis and aspergillosis in blue and orange, and higher value in green in case of pneumocystosis with a median of 54 picogram per ml. In the literature, 16 recent studies describe the performance of the Fujiti-Wako test. Many of them have already been presented. However, these studies focus on different types of invasive fungal infection, sometimes aspergillosis, sometimes candidiasis, or all of the hyphae. Sensitivity and predictive, the studies used various cutoff, the manufacturer's cutoff or an homemade cutoff, and involved heterogeneous patient population. Sensitivity and positive predictive value vary widely, while specificity and negative predictive value are consistently high. The difference compared to your study partly due to the population we analyzed. We work under real-life conditions, including all patients who have a BDG test with a significant proportion of individuals who may have potential interference, such as treatment with albumin, immunoglobulin, or beta-lactamine. These assays show an excellent predictive value, making it a reliable tool for ruling out invasive fungal disease. In case of a positive result, it's important to perform a second sampling to rule out potential interference. And it's recommended to combine with specific biomarkers such as antigen or PCR and or phenotypic method, direct examination culture, to improve diagnostic accuracy. Serum BDG testing is part of several recommendations for diagnostic hyphae, but what about other samples? I saw this morning a poster about BDG in high-state liquid. We speak about other matrices in this talk. A team in Paris has worked on BDG testing in cerebrospinal fluid. These studies show promising performance in a population divided into 5 groups based on the classification of cerebral hyphae. Thus, BDG should be integrated in the diagnostic arsenal in CSF for early detection of cerebral hyphae, excluding, of course, cryptococcosis. Together with one of our ICU colleagues, we studied the usefulness of BDG testing, not only in serum, but also in peritoneal fluid for diagnosing intra-abdominal candidiasis. In peritoneal fluid, a higher cutoff of 45 picogram per ml shows the best performance for identifying candidiasis. Our conclusion are that a peritoneal score below 3 combined with a peritoneal BDG level under 45 picogram per ml and an undetectable serum BDG level allow us to exclude 100% of intra-abdominal candidiasis case. Together with our ICU colleague, we are now working on combining biomarkers for the diagnosis of intra-abdominal candidiasis in liquid peritoneal fluid. 80 peritoneal fluid samples from the previous study was analyzed, selected patients with or without intra-abdominal candidiasis. The samples are clinically, mycologically characterized, including direct examination on culture, along with a BDG value measured in both serum and peritoneal fluid. In this context, we test the qPCR CON-ID from OLM. This PCR detects Candida albicans, Candida glabrata, Candida parapsilosis, Candida tropicalis, Candida krusei, and Candida dubliniensis. The data are currently being processed. However, preliminary conclusions show an excellent detection of potential Candida species in peritoneal fluid, a good correlation within fungal culture at the threshold of 30, and a value of combining BDG and Candida PCR to rule out intra-abdominal candidiasis and discontinue antifungal therapy. To conclude, BDG is an excellent biomarker in the context of challenging diagnosis. Combining different diagnostic strategies is essential to improve overall performance. Caution is needed regarding other IFE, such as mucormycosis or cryptococcosis, and promising perspective also lie in exploring other sample type for diagnosing molecularized infection. Thank you for your attention, and see you soon in Nancy.
So thank you so much for sharing your personal validation data and your study data with us. I think this raises also some questions to you, and also the issue of other sample types, like peritoneal samples, might be very interesting. So both the lectures now are open for questions. So I think, yeah, the microphone is there. Is there somebody who has a question for one of the speakers? Something? Ah, yeah, there is a question.
Yes, hello. Thank you for the talks. I'd like to ask a question to Anne. You say to repeat the test if it's positive to increase the sensitivity. What's the delay between the two tests? What delay do you recommend to avoid interferences?
In this study, we study a period of 15 days. But in practice, a new sample 4 or 5 days later could be interesting. We know that people we have immunoglobulin interference decrease really very rapidly after the administration. So we can try 3 days, 5 days after this kind of treatment.
Hello. My name is Tihana Bicanic. I work at St George's Hospital in London. We've also, similar to the first speaker, went from send away Fungitel to Waco test implementation, also for the same reasons like you. Also had clinicians not knowing how to interpret it. But what I have found, and we haven't analysed like Anne has done yet, our testing has gone through the roof. So there I was trying to bring the test for stewardship purposes, campaigning with my microlab. Took about 2 years to convince them. And I'm finding we also have an algorithm for using when to send the test in ICU with a certain Candida risk score, and then send a beta-D-glucan, start empirica kinocandins. But I'm finding that not only are more specialties sending the test, so the testing has gone through the roof, but also they just keep repeating it. We also say, like Anne, repeat if it's positive, repeat if it's negative, you can trust it, it's a good negative predictive value. However, we're just getting ICUs repeating it time and time again, sending in patients who already have confirmed candidemia. and other specialties like hemato-oncology sending it because we don't have Aspergillus PCR, we just have galactomannan. So I'm just curious to know, what have you done in your institutions, or are you doing to try and streamline which groups? Do you block certain groups and say only certain people can order it, or only do it twice, or you just reflexively test everything? Because the danger is that the test population we validated it in, we then have a population with much lower pretest probability, and all our performance values that we based our validation on are out the window. So sorry, that's a long-winded both comment and question for both of you.
Should I start? Yes, thank you. That's a very good comment, actually. And I mean, if you ask clinicians, would you like this test that used to take 5 days, would you like to have it with the result within 2 hours? It's like no one can say no to that. Of course, it's very, very tempting to order it. But actually, our figures show that this year we are actually performing slightly lower number than we did the last year before introducing it. So it hasn't gone through the roof, as you describe it. I don't think there is any secret. Well, the secret is that this perhaps is kept as a secret for all clinicians except the ID physicians. And it's usually ordered, I would say 90% of times it's ordered in either by the ID physicians or after consulting the ID physicians. I don't think the news of us performing this and the knowledge about this hasn't really spread to the ICU doctors this far at least. So we were also aware of this. We were also aware that we needed to monitor the development of the number of tests, but this hasn't changed actually. And as you say, one problem then is that you increase the clinical presentations where this is used, and you reduce the pre-testing probability, which will then, of course, reduce the specificity greatly. But this far, it has not been a problem in our hospital, at least.
We can say the same answer. Clinician asks the biomarker if the patient presents symptom compatible with HIFI. We see this information in the survey, so we don't be afraid about an extensive prescription rate. Mm.
I can answer also from our center. Also there it seems quite stable, I think, the number of tests we get. But I think indeed it's very, very important to keep this testing in certain strategies where results have an impact, either to start or to stop therapy. And when you see it's really increasing, I would also check where does these samples come from, and then get in touch with these clinicians, this group of clinicians, and try to come to real algorithms where you clearly say, there we can test and otherwise we won't. Because for many tests, it might be, oh, it's nice to have an additional result, an additional PCR, an additional antigen, but I think we all need to strive to have additional results for tests that really do impact and not just are an add-on in the dossier. But it might not always be so easy to realize that in clinical practice.
Thank you.
May I add just a brief comment? I think one of the things that I think we have achieved, actually, we haven't measured that, but what I think has been a big advantage of having these rapid results is that we probably have reduced the number of patients being put on empirical cotrimoxazole for pneumocystis pneumonia suspicion, which is, of course, of great advantage. Is these patients are quite often, they have some renal failure, and avoiding unnecessary treatment is probably one of the biggest advantages, I would say.
Thank you for the two speakers. I would like to ask you for both. We have been using the work of beta-glucan for more than 3 years, and we have a problem with the samples who have values about the cutoff, 8 picograms, 6 picograms. Don't you think that in order to inform to the clinicians, we should establish some gray zone about the 10 or the 20% between the cutoff. What is your opinion?
In our lab, we use a green zone between 6 and 8, and we ask a new prelevement in the conclusion of the analysis.
I think it's a bit an issue with all tests. It's not when it's below the cutoff, it's negative and no suspicion at all, and when it's just a little bit more than it's truly positive. If you would repeat around the cutoff your sample 10 times, half of it would be under, half of it would be above. But the good thing is that I think you report the actionable result. I mean, if it's just under the cutoff, that you see the value and you can see it is just below the cutoff. This is informative, and I thought I found it very interesting in your talk, and I think that's something we will implement, is that you have this extra comment when it's below the cutoff but higher than the detection limit, that you add this comment that it might be interesting to send in a new sample, because we know that also in patients with invasive fungal infections you may be below this cutoff. So I thought, of course it really depends on your setting, but I think this is a very important thing. I don't know how you came to this. Was this based on literature or?
No, it was based on the papers, especially the first one from Freiburg, when they said that the cutoff of even a lower cutoff makes WACO slightly less sensitive to candidiasis. So that was mainly the reason. But as you say, again, very few tests are sort of dichotomous in that way, that super negative or super positive. So if they're around the cutoff, the qualitative interpretation may vary if you repeat the test, of course. Yes, what we also do, I mean, there are different ways of doing this, as always in microbiology, to either comment or to communicate verbally. But what we do, since we're a small laboratory, we actually communicate all positive results over phone to clinicians, and we ask about the clinical presentation, and we sort of emphasize that this is only one piece of the puzzle, and it needs to be put together with other, especially clinical data. But I think actually the introduction of the WACO test did not introduce this new phenomenon. I think clinicians also were used to having like Fungitel 97 picograms, for example, was also like a gray zone result. So I think they were already used to having weak positive samples results questioned from a clinical point of view.
Any other questions?
Gemma Johnson from IMI. I just wanted to comment on the cutoff value as well, that I know there are a couple of centres in the UK who also use this method of, if they have 6 picograms, they'll request a repeat sample. And they will report that as a query positive. And for those centres, it came from a long period of validation study in centre, where they found that for the majority of the samples that came in at 6, they were only going in this direction. And when they repeat, they were always rising. So they take the 6 as an early indicator.
Mm-hmm. Thank you very much for this comment. I think, it's really concordant what you see here. And I think that it's most useful. It's also with many markers, and also if you look at antibody production, for instance, you see things are being produced, and it all depends on your timing of your sampling. And that was something I wanted to ask to you, because the really superb sensitivity was striking in your study. It was so high, also if you compare. I was thinking, might this be related to the timing of the sampling? Or have you any idea why the sensitivity is so high in your hands, higher than in most other studies?
I don't know. We randomly include 100%. We can test more patients. Perhaps it's a bias of the study, but I don't know exactly why we have a good result.
But I think perhaps also, as was mentioned here, that the selection of patients affects strongly the sensitivity and the specificity. And the fact that we have been able to keep this a secret sort of tool means that it's perhaps still used in the correct patients, and we don't see any big problems with specificity actually. So very few are so false positives in our from our experience.
Any other questions? If not, I think we can conclude this session. I want to thank both speakers. I think their personal results and their personal experiences was very valuable for me, but I guess also for you. And I want to thank you for your interaction, and I only can wish you now a very pleasant evening and a good conclusion of the Congress.